Good morning. We're about to begin. Indicate if you can hear me. All right, so it is the beginning of week 4. And for this week, the focus will be on the medical emergencies module. Majority of the medical emergency chapters. So the medical emergency module is module 6. It has 10 chapters. 6 out of the 10 chapters are already recorded and stored on the platform. So the focus will really be on the remaining 4 medical chapters and environmental emergencies. So we're starting with medical overview. And the focus, this is the first chapter in the medical module. The focus of this chapter is to give you an idea in terms of what is required or what should be considered when assessing a medical patient, right? So you need to pay attention to what would be different in your approach in comparison to a trauma patient. All right, so introduction. Patients who need EMS assistance generally have experienced a medical emergency. Yes, Miss Cephas.
Was that accident, sir? Sorry.
Patients who need EMS assistance generally have experienced a medical emergency, a trauma emergency, or they may have experienced a combination of both. Trauma emergencies involve injuries resulting from physical forces applied to the body. We know this at this point. Medical emergencies involve illnesses or conditions caused by disease. Types of medical emergencies. Respiratory emergencies. So we'll be looking at respiratory emergencies. This is patients who have trouble breathing or the amount of oxygen supplied to tissues is inadequate. We'll be looking at cardiovascular emergencies, which is caused by conditions that affect the components of the circulatory system, whether that is the blood vessels, or the heart itself. We'll be looking at neurologic emergencies. This is specific to complications with the brain. We'll be looking at gastrointestinal conditions, which include appendicitis, diverticulitis, pancreatitis, and many others. We'll be looking at urologic emergencies, example, kidney stones, endocrine emergencies. These are the ones that are specific to diabetes mellitus. Hematologic emergencies, which can either be a bleeding or clotting disorder. Immunologic emergencies, these are going to be the emergencies that are specific to severe allergic reactions. Toxicology, that's going to be more specific to drug overdose or adverse effects from overdosing on illegal drugs, sometimes prescriptive. Gynecologic emergencies will be emergencies that are specific to the female reproductive system. So all of these emergencies will be covered in the medical emergency modules, not in this specific chapter. So there is a chapter dedicated to each of these emergencies. Now, some medical emergencies are caused by psychological or behavioral problems, that psychiatric emergencies may be especially difficult to deal with because patients do not present with typical signs and symptoms. All right, now let's look at the patient assessment for a medical patient. And again, pay attention to what would be different as it relates to your trauma patient. Similar to the assessment of the trauma patient, but with a different focus. Focus on the nature of illness, the symptoms, the chief complaint. Establish an accurate medical history. So history, your ability to obtain history from a medical patient will be very essential to the way that patient is managed or treated. Use dispatch information to guide your initial response. Do not get locked into a preconceived idea of the patient's condition. Injuries may distract from underlying condition. So with your medical patient, the medical patient can present with typical signs and symptoms, and they can have atypical presentation. You have to be able to perform a thorough assessment and obtain good information as it relates to the history to determine your path as it relates to treatment of the patient. Assessment may be difficult with uncooperative or hostile patients. Maintain a professional, calm, and non-judgmental demeanor. Refrain from labeling patients. A frequent caller may have a different complaint this time. So don't label your patient, and if it's somebody that calls the service regularly, be open-minded. It could be that something is seriously wrong why they are calling at this point in time. All right, the scene size up. So scene safety, make certain that the scene is safe. You're going to use standard precautions, determine the number of patients and whether you need additional help. Consider the nature of illness. This is the reason the patient activated EMS, or the reason EMS was called. This is what the patient complains of. Determine the NOI, index of suspicion. This is going to be your awareness of potential serious underlying injuries or illnesses. Once you have completed your scene size up, the next phase of your assessment is your primary assessment. You're going to form a general impression. Develop a general impression, perform a rapid examination of the patient. Visual clues include apparent unconsciousness, obvious severe bleeding, extreme difficulty breathing. Quickly determine the patient's level of consciousness. After you have determined the patient's level of consciousness, next is airway and breathing. In conscious patients, ensure that the airway is open and they are breathing adequately. So once a patient has a patent airway, your focus shifts to the lower airway. So you're going to check the respiratory rate, the depth, and quality of breathing. And of course, you're going to consider the regularity. Consider applying oxygen if breathing has been affected. For unconscious patients, make sure to open the airway using the most appropriate technique. Apply oxygen to patients who you suspect is in a state of shock, or going into shock, I should say. With difficulty breathing, definitely. When low oxygen saturations are measured, and the patient's presentation can be linked to that low O2 reading. Unconscious patients may need airway adjuncts and ventilatory assistance with a bag valve mask. You must look for the indicators before these equipments are utilized. Circulation, assess in a conscious patient by checking the radial pulse and observing the patient's skin color, temperature, and condition. For unconscious patients, assess at the carotid artery. These are things we should know at this point. Transport decision. So after you have completed your ABCs, what is your transport decision based on the findings? Patients in need of rapid transport, unconscious or have an altered mental status, airway or breathing problems, obvious circulation problems such as severe bleeding or signs of shock. History taking. Determine what the problem is or what may be causing the problem. Get a thorough history from the patient, any family, friends, or bystanders. For an unconscious patient, survey the scene for medication, containers, or medical devices. Obtain a sample history and use the OPQRST mnemonic. Record any allergies, medical conditions, and medications that the patient is taking. Some patients take numerous medications. Take the medications with you to the hospital. History taking, a mnemonic to consider, TACOs, which means tobacco, or the T is tobacco, the A, alcohol, C is caffeine, O, over-the-counter medications or herbal supplements, S, sexual or street drugs. Things to consider. Scan the scene for clues about the patient's medical history. Once you have completed the history-taking phase, next would be a secondary assessment. May occur unseen or en route to the ED. In some cases, you may not have enough time. Physical examination. All conscious patients should undergo a limited or detailed physical examination. For unconscious patients, always perform a secondary assessment of the entire body or a head-to-toe examination. Physical examination include examine the head, scalp, and face. Examine the neck closely, assess the chest and abdomen, palpate the legs and arms, examine the patient's back. However, at this point in time, we are not only focusing on trauma, we're focusing on medical conditions as well. So, does the left pupil react the same as the right? Are the pupils moving together? Is there symmetry? Does the right side of the face match the left side of the face? Is there unusual odors coming from the patient's mouth? Are there signs of rashes or signs of infection? Are there signs of an abscess? Right? So are there track marks on the patient's arm or arms? So you're not only looking for trauma, you're looking for medical clues, things that could indicate an underlying medical condition. In your secondary assessment, you will also be doing your recorded vital signs. So assess the pulse for rate, quality, and regularity. Identify the rate, quality, and regularity of the respiration. Obtain an initial blood pressure. Consider obtaining a blood glucose level and pulse oximetry reading. So any patient in which you find unresponsive on a location or scene, and you're not able to get adequate information in terms of how this patient lost consciousness, ensure that you examine their pupil. So check the pupil reaction, look at the pulse oximetry reading, and ensure that you get a blood glucose level assessment. After you have completed your secondary assessment, the final phase is your reassessment, performed once the assessment and treatment have been completed, begins and continues throughout transport. Consider the need for ALS backup, reassess interventions, document any developed changes or any changes that develop. All right, now management, transport, and destination. Most medical emergencies will require a level of treatment beyond that available in the pre-hospital setting. May require advanced testing available in a hospital. It may be beyond the scope of the EMT to administer medication or medications to a patient. EMTs can use an AED, and EMTs can use the basic features of a cardiac monitor, and it is preferred, or I would suggest that it's better to have a cardiac monitor than have a AED on the ambulance. Scene time. Now with your medical patients, you may have to spend time on that scene to gather information, right? You may have to spend some time to gather information. However, you must recognize when a patient is critical and requires rapid transport. An average medical call, well, I don't want to say average, but a medical call can take 25 minutes in the States on scene or longer. Now, what the philosophy is in the States, because there is BLS and ALS. As an ALS provider, I was taught that if there is a problem I can fix it in the field, right? So if the patient presents with a medical issue as an ALS provider, once I am capable of fixing, whether it be a particular procedure or medication, I should administer that medication to fix the problem, because the same thing that I am going to do in the field is the same thing the doctor would do in the hospital. So the faster it can be done for the patient, the better the patient's chance of recovery. That's from an ALS perspective, right? So I can spend 25 minutes on a scene to wake up a patient, and I have done that, and I have spent longer, right? Because I know what was needed, I provided what was needed, and the patient woke up. But in a Jamaican context, that will not work, because there is only BLS response available in Jamaica. No, it doesn't mean that you shouldn't spend time to gather information. That is going to be important, and that is what you need to put a lot of emphasis on, right? Your ability to communicate and get information as it relates to the patient history, and quickly relay that information to the receiving facility. Your management will be centered around managing ABCs. Depending on your protocol, you may be allowed to assist the patient with certain medications. You may be allowed to administer certain medications once the indication is present, right? But you will have to spend some time to gather information. However, if the patient is critical, rapid transport, and you're going to see that commonly with your very old and your very young patients. So these patients are, once critical, you need to move. Now, type of transport. Life-threatening conditions, lights and sirens. But you have to be careful, right? So there are some patients, even though their condition might be life-threatening, you cannot use the lights with the sirens, right? So your patient that is having a suspected heart attack, you might want to go easy on the sirens for that patient because it can cause the patient's heart rate to go up and trigger dysrhythmias or arrhythmias, which is abnormal heartbeats. Also, for your patient that you suspect might be a epileptic patient or a patient with severe migraines, right? And sensitivity to light. These are patients in which you may have to adjust your lights and sirens use for these patients. Right now in Jamaica, I don't know what the law is as it relates to lights and sirens in the states. Each states have their own guidelines, right? So each states have specific guidelines. For instance, in Texas, where I was working, specifically Abilene, Texas. No, that was Fort Worth. In Fort Worth, Texas, if you are passing a school, so if you're heading to an emergency or you have a critical patient on board, lights and sirens, and you're about to pass a school, you have to turn the lights and sirens off and reduce your speed. And you communicate that information to dispatch. And once you have passed the location where the school is, the sirens and lights can go back on. Also, if in Fort Worth, if you come to an intersection, lights and sirens, so you're coming to an intersection and there is a vehicle in front of your ambulance, right? That's a vehicle that is supposed to be going through the light when it changes. If a vehicle is in front of me, I have to turn off my sirens and lights and call dispatch and tell dispatch that I am in traffic. I cannot force that vehicle force that vehicle through the light. Now, if the ambulance is the first vehicle to reach the light, then once I am given permission by the other drivers to pass, I can pass. So the laws are very, very specific in the states. I don't know what exists in Jamaica. That information I've tried to obtain, not able to obtain it. So life-threatening conditions, generally, lights and sirens. You will be guided by state laws and your protocol and medical direction. Non-life-threatening condition, consider non-emergency transport. Modes of transport ultimately come in one of two categories. It can be ground transport or it can be air transport. Ground transport EMS units are generally staffed by EMTs and paramedics. Air transport EMS units are generally staffed by critical care transport professionals. So this can be a paramedic and a nurse, or it can be a paramedic that is a nurse. It can be a paramedic and a physician. So in the UK, they have field physicians. So it can be a paramedic and a field physician. But usually a critical care transport paramedic has done some training beyond paramedicine. So they are usually either nurses or they have gone on to become respiratory therapists, right? or they are doctors, but they usually have something more because it's a very competitive field. So just having your paramedic qualification alone is not enough. And it may be enough if you have completed a critical care transport course, but if you're a paramedic and nurse with critical transport certification, you'll have a better chance of getting a job in that area. All right, now destination selection. Generally, the closest hospital should be your destination. At times, the patient will benefit from going to another hospital capable of handling his or her particular condition. You will be guided by your protocols. All right, so the remaining portion of the chapter is focused on infectious diseases. The first half of the chapter is what is important. This portion is also important. You won't get a lot of questions on it, but it is important in the context of what is happening worldwide as it relates to COVID-19. So, general assessment principles for infectious diseases. Approach like any other medical patient. Perform scene size up, take standard precautions, and complete primary assessment. And for these patients, PPE is essential. So standard PPE needs to be emphasized for these patients. You need infection prevention control measures, right? So that must be a part of protocols for these patients. Get a patient history using OPQRST to elaborate on the patient's chief complaint. General assessment principles. Obtain a sample history and a set of baseline vital signs. Trust your instinct, right? Because with the COVID-19 situation, one of the things that is happening with the Jamaica Fire Brigade response is that persons are calling for other complaints outside of the COVID-19. So they know that they're probably having symptoms that are linked to COVID-19. But when they call the fire brigade, they are not telling them that. They are telling them something else. And when the fire brigade EMS responds, they are finding out unseen now that is a possible COVID-19 patient, right? So they are not giving accurate information because of the stigma associated with COVID-19 positive patients. And the solution to that is you need to approach every patient with possible signs of infectious diseases or communicable disease as if they are contagious. And for COVID, you need to practice the recommended guidelines. So you should be at least 6 feet away from your patient when you're doing an assessment once possible, right? And if you need to do hands-on and it is necessary for the patient, then you need to have on your proper PPE. Ask whether the patient has recently traveled or has come in contact with someone who has traveled. General management principles. Focus on life-threatening conditions identified in the primary assessment. Be empathetic. Place the patient in the position of comfort on the stretcher and keep them warm. Use standard precautions. Endemic and pandemic consideration. An endemic is new cases of a disease in a human population new cases of a disease in a human population substantially exceed what is expected. That is an epidemic. A pandemic is when the disease is spreading globally, right? So a disease outbreak that occurs on a global scale. All right, so influenza or flu, an animal respiratory disease that has mutated to infect humans. those with chronic medical conditions, compromised immune system, and the very young and the very old are most susceptible to the complications of influenza. So it can cause the lower respiratory tract to become infected. They can develop pneumonia, and that can lead to sepsis, and they can die, or they can die from the pneumonia, depending on their age, whether they're young or old. Transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing by an infected person. So that's influenza. And to work in an EMS system in the States, you are required to take a flu vaccine yearly, right? And for some people, when they take the vaccine, they get sick. If I take the flu vaccine, I'm gonna get sick after, but I'm good for the next 2 years. All right, now H1N1, initially identified as the swine flu, present for years in animals, initially identified in 2009, caused many deaths. Increased awareness of routes of transmission is necessary. All right, for diseases that can be passed by the respiratory route, always wear your PPE, gloves, eye protection, HEPA respirator. HEPA respirator is preferred. And if you're using a N95, you have to be fit tested for the mask, and the mask must be seal tested, right? So you have to be fit tested, meaning you have to get a mask that forms a perfect seal based on how your face is shaped. And that mask that you're getting must be seal tested. So they have to do a test with that mask to ensure that no particles can pass through the filters. Place a surgical mask on the patient with suspected or confirmed respiratory disease. And that goes for COVID as well. So if you suspect that a patient is having COVID, when you arrive on the location, if they don't have a mask, give them one to put on. Annual influenza immunization is important for EMS personnel to protect providers and patients. So that's influenza. Let's look at herpes simplex. Now, the herpes simplex, common virus strain carried by humans of individuals carrying the virus, 80% are asymptomatic. And we know what that word means by now, right? So they don't show symptoms. Symptomatic infection cause vesicles that appear on the lips and the genital region. It can cause more serious illness in susceptible patients. Primary mode of infection is through close or personal contact. Next, we have HIV infection. EMTs face a risk of exposure. No vaccine yet exists. AIDS can still be fatal, however, with treatment, and that's not cheap treatment, that's expensive treatment. With treatment, patients can expect a near normal lifespan. Not easily transmitted in the work setting, your risk of infection is limited to exposure to an infected patient's blood or body fluids. And my experience with interacting with these type of patients, usually, well, I won't say usually, but the patients that I encountered actually gave me indicators. Like they would say to me, hey, make sure you wear your gloves, be careful how you do this, be careful how you do that. I have had that experience with these types of patients. They normally tell you, say, make sure you're taking proper precautions when you're interacting with them. That was my experience. I don't know if that is the experience right across the board. That may differ because it's a personal experience for me. So I can't really generalize that. Many patients with HIV show no symptoms. Always wear proper type gloves. Take great care in handling and disposing of needles. Cover any open wounds. If you think a patient's blood or secretions may have entered your system, seek medical advice. Notify your infection disease officer. And every service in the States have a infection disease officer or infection control officer, Department Infection Control Officer, non-existent in Jamaica. Right, now hepatitis, inflammation and often infection of the liver. I have various types of hepatitis. This is A, B, C, D, and E. Early signs: loss of appetite, vomiting, fever, fatigue, sore throat, cough, muscle and joint pain. Later signs: jaundice, right upper quadrant abdominal pain. They can have toxin-induced hepatitis, which is not contagious. There is no sure way to tell which hepatitis the patients have, so we will assume that it is the contagious form. Now, it is recommended in EMS that you obtain your hepatitis B vaccine and, of course, maintain that based on the recommended dates for boosters. But they have started to combine the hepatitis A and B vaccine. Right now, patients that abuse drugs via needles are high risk for hepatitis C, which is the hepatitis that will lead to cirrhosis. That's the one that causes cirrhosis of the liver. So they should probably consider making a vaccine for hepatitis C. All right, now meningitis. This is inflammation of the meningeal covering of the brain and the spinal, so that's the membrane. Signs and symptoms include fever, headache, stiff neck, altered mental status. They can get photosensitivity as well. They are at risk for seizures too. Most forms of meningitis are not contagious, right? But the meningococcal meningitis is highly contagious. Take standard precautions. Meningitis can be treated at the ED with antibiotics. After treating a meningitis patient, contact your employer and health representative. And you are also required to get a vaccine for meningitis in the state. So that's a requirement to work in a service in the state. It is not, the vaccine is not out here, right? I had issues getting that vaccine when I needed to leave for my rotation in the States. I had to get it overseas. Right, now tuberculosis. Many infected patients are well most of the time. Tuberculosis is a mycobacterial disease that usually will affect the lungs. Patients who pose the highest risk almost always have a cough. And this is going to be a cough that lingers for weeks. Consider respiratory tuberculosis to be the only contagious form. You definitely need a N95, you need a HEPA mask, are required to stop the droplet. Infectious agents can take hold in some patients much more easily because of reduced defense. So elderly patients are at risk. People who are immunocompromised or immunosuppressed from chronic illnesses, cancer treatment, or transplant, these patients will be at risk. Absolute protection from the tubercle bacillus does not exist, so you cannot get full protection. 1/3 of the world's population is infected with tuberculosis, but it might not be active. So they might have it, but it's not active in their body. The vaccine is rarely used in the United States. Mechanism of transmission is not efficient. In EMS, you're required to do a tuberculin skin test regularly, right? And it's done every year. In Jamaica, you can get the test done. If it's positive, then you need to do a chest x-ray to ensure that nothing is wrong with the lungs. Next, we have whooping cough or pertussis, common in your pediatric population, usually younger than 6 years of age. Symptoms is gonna include fever and a whoop sound that occurs when inhaling, a very distinct whooping sound after coughing attack. So they have a terrible coughing fit and then a whooping, a pulling in. You have to draw in ears, work to pull that ear into the lungs, and it creates this whooping sound. It's also known as the 100-day cough. The best way to prevent exposure is to be vaccinated. Place a mask on the patient and yourself. All right, now Methicillin-Resistant Staphylococcus aureus, or MRSA. MRSA is a bacterium that causes infections, right? So what this is a bacteria that is resistant to antibiotics, right? It is in the healthcare setting. MRSA is transmitted from patient to patient by healthcare providers and unwashed hands. It is common in environments like the old age homes where they are not clean, or in the hospital where they don't practice proper sterile procedures. Well, MRSA is common. Factors that increase the risk of MRSA: antibiotic therapy. So the person is on antibiotic therapy for an infection and they don't follow the regimen, right? So they start to feel better. They take the antibiotic, start to feel better. As soon as they start to feel better, they stop taking the medication. So what you have done now is you have introduced the medication to the bacteria, but you have not removed the bacteria completely from your body. So the bacteria now adapts to the antibiotic and becomes resistant. It can occur from prolonged hospital stays, a stay in an intensive care or burn unit, exposure to an infected patient. MRSA results in soft tissue infection, localized skin abscess, and sepsis in older patients is possible. All right, now global issues. MERS-CoV, Middle East Respiratory Syndrome, coronavirus. First human case discovered in 2012 in Saudi Arabia. So from 2012, the information was out there that it is possible that a coronavirus could cause a global issue, right? So it's not new information. It has been out there and preparation should have started from then. Anyway, first human case discovered in 2012 in Saudi Arabia. Common patient symptoms include high fever, cough, muscle aches, vomiting, diarrhea, and in some cases it can cause renal failure, respiratory failure, and death. No cure or vaccine for this virus at present, right? So then from 2012, they knew, okay, this is a unique virus and it could really cause a problem globally. But does it affect my country? It's not affecting my country, so we don't need to put any preparation into place for this. And we're reaping the results of that. All right, now the Ebola virus. In 2014, outbreak of Ebola virus occurred in West Africa. The incubation period is 6 to 12 days after exposure. Right? Symptoms may not appear for as long as 21 days after the infection, and the symptoms were linked to watery diarrhea, vomiting, bleeding, body aches, and bleeding. The fatality rate can be as high as 70% if treatment in an ICU is not initiated promptly. Travel medicine. You must be aware of travel-acquired infections when assessing a patient who was recently outside of the US or recently outside of Jamaica, because the US might be the most contagious country in the world right now as it relates to corona. So if you're interacting with any foreigner from the US, you need to be taking all the necessary precautions. Patients can present with a variety of symptoms. When you encounter an ill patient with recent travel history, place a mask on the patient, maintain that 6 feet distance, get as much information as you can. If you have to breach that distance, ensure that you have the appropriate PPE to do so. Important questions to ask, or important questions to include. Where did you recently travel? Did you receive any vaccinations before your trip? Were you exposed to any infectious diseases? Is there anyone else in your travel party who is sick? What types of food did you eat? What was your source of drinking water? Conclusion. Assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. And I have said to you last week that it is much more difficult to assess and manage a critical medical patient than it is to address trauma issues, right? Because it can be a typical presentation, it can be atypical, or you might not be able to get the information that you need to find out what is going on. So you really have to think critically when dealing with these patients. The condition of a medical patient may not be as apparent as in a trauma patient, and treatment may not be as straightforward. Patients sometimes have more than one isolated problem, right? And that is an overview of how you will approach and assess your medical patients and things that you need to consider for specific infectious diseases. And that brings us to the end of this chapter. Are there any questions? Okay. If there are no questions, then we will take, let me see the time. We will take a 10-minute break. We will resume at, well, let me see. Yeah, we will resume at 9:30.